All right, whenever y'all are ready. All right. Well, everybody, welcome to our February SHARC Research Seminar. Glad to have you here in person. Glad to have you here on Zoom. I think I know most of you in the room, or not everybody though. Bob Cook, I'm the director of the SHARC. And I'm really pleased to introduce Dr. Bruce Rollman. I've known Bruce for at least 30-something years. My first job as a faculty member was at the University of Pittsburgh, and Bruce was there at the University of Pittsburgh 1 year before me. Bruce is still at the University of Pittsburgh. He's been there over 30 years. He's now a professor. He's an endowed chair. He is this research center director. And it lists on the website that he's a professor with 4 different affiliations: medicine, psychiatry, clinical and translational science, biomedical informatics. Dr. Rollman was telling us this morning about some patents he did when he was younger, and now he's led a lot of large research projects that require the NIH to approve budgets over the maximum allowed amount. He's done clinical trials, he's led research teams, and he's done a lot really trying to think about how do we intervene on behavioral health in a primary care health system. So I'm really glad to have Dr. Rollman here today, and thrilled that he's here in Florida on a very sunny day. So let's give a big round of sharp applause for Dr. Bruce Rollman.
I don't know how the sound is or people at home can hear, but I want to say thank you to Bob for inviting me. We've been friends. Our kids in a way grew up together, and our wives used to hang out in a baby group for many years and so on when our kids were little. But this is my first time in Gainesville, and it's been great so far. And I hope, although when I was looking at the website and Bob was saying, well, who would you like to meet with and so on, my work is a little bit different from the work here. It's less focused on HIV and alcohol and so on, but I think that there's a lot of overlaps and maybe some things as we get to know each other a little bit where maybe we could kind of share some ideas, and just having these kind of discussions raise new points. So without further ado, so I don't have anything really to disclose. And the presentations from today is really to present I have 2 lines of work. One line of work has been NHLBI funded, our work in heart disease, and our work in primary care has been NIMH funded. So I really want to focus on presenting our work in really just over 20 years of work in primary care, in treating anxiety and depression through a collaborative care approach, which we'll talk about. We'll describe the model. We'll show also about recruitment. That's always an issue, as I heard this morning meeting with the group. We'll talk about how we use EPIC best practice alerts to reach our recruitment goals and so on, and how they compare to more traditional forms of recruitment by hiring people in waiting rooms to screen. And then we'll also talk about some future developments in mobile health and steps needed to really advance the scientific field. One of our slides will be from a paper we just published in December, talking about digital health equity and digital health, which is part of digital health readiness. So anyway, without further ado, so primary care physicians often encounter people with depression. It's fairly common in primary care, depression and anxiety. But recognition of these conditions has been low. Even when you screen and provide feedback to primary care doctors, that screening and feedback has really not been shown to make a difference. And even so, the treatment has been inadequate. Even when you tell the primary care doctor, person in front of you has screened positive on a PHQ-9 or a GAD-7 or something for a mood or anxiety disorder. And it's also difficult to get people into mental health specialty care. That's another thing too. Once you have a person, like in a lot of things, it's very hard, even pre-pandemic, to get people into care and to get people into care reasonably quickly. I've had 6 R01s that have been PI on. My very first one, I wrote my first year on faculty in 1995. 1995. And then it ended up, it was an AHRQ funded trial to implement the depression care guidelines that AHRQ'd, then AHCPR was known to implement into primary care using the electronic health record system. So our practice went electronic in 1996, and The first R01 trial was to screen and inform doctors if their patients were depressed or not, and then to give advice both on messages, electronic messages, and on printed visit summaries. And at the end of the day, we found that the trial was a negative trial. There was no difference between the usual care arms and actively or passively presenting information to the PCP. And I was thinking to myself, what did I do wrong? Maybe like there had been a lot of work on electronic health records showing that they improve quality of care. And indeed, I went back to the literature and I saw that they were good on improving care for one-time only things. So a flu shot, a mammogram, a recommendation for a colon screen, and so on. But for chronic illness care was different. So our trial was negative, and two other people, David Bates at the Brigham and Bill Tierney, then at Regent Strife, also were funded on this RFA, and they had negative trials for heart failure and diabetes, and they were like super experienced people. So I thought, okay, maybe we're just using the model wrong. And I'd had this idea about push-pull marketing, and push being how interventions are traditionally pushed out. But you publish something in a journal, and then hopefully the doctors pick it up and use that practice, versus pull marketing, which is what the drug companies were doing, like through direct-to-consumer ads, where they would advertise a new product on TV or in a magazine. And then if the patient went to the doctor's office and asked for the medication or a test or something, they were more likely to get it. So around that time, I was thinking about push-pull marketing. This Wagner chronic care model had come out. And Ed Wagner, who was at the time at Group Health Cooperative in Seattle, came up with this chronic care model. And this chronic care model is basically this team approach. It's now called like collaborative care or patient-centered medical home. It has very similar names, but basically it's a team approach. It's within primary care, using care managers, non-physician care managers, who could be nurses or they don't have to be. But we're using registries, and we're proactively contacting patients between visits, to follow up on their care, and with a specialist backup as needed. So this model of chronic care has been shown to be effective and cost-effective for conditions like diabetes, heart failure, COPD, asthma, et cetera. And around that time in the mid-late 90s, there was an emerging literature on using collaborative care to treat depression in primary care by teams led by Wayne Caton at the University of Washington in Seattle. But nobody had actually applied this before to anxiety disorders. So I was kicking around ideas at the time. Okay, our first depression trial was a negative trial. Nobody's going to fund me on depression again, especially being a junior investigator. So I kind of shifted to anxiety disorders because nobody else was doing anxiety, and also with collaborative care for anxiety. So, well, let's go back here with depression. I mean, it's common, this collaborative care, there were just so many randomized trials that have been done by now. It probably isn't need to do another randomized trial of collaborative care for depression. And we had done some so I was moving into the anxiety, kind of like seeing where there might be an ecologic niche for our work. Anyways, long and the short of it, this is the other advantage of being an older person in this field, is by now it's billable. So one of the limitations, even with all these positive trials for many years, is that how are you going to pay for the care manager role? So we're talking this morning about an other pockets problem, as they say in economics, where someone would benefit, the primary care practices would have to pay for the care manager. But we and others have shown that these care managers are very cost effective, but who's reaping the benefits? Often the insurance companies, right? They have to spend less, or they can spend less if depression is being adequately treated. So it really, and this is through the work of a lot of other people working in policy and whatever, CMS is now covering the time. There are billing codes now for the care manager that there wasn't before, but it's only taken about 25 years to do this kind of work. So our team has conducted over this period of time I mentioned the first trial was not a collaborative care trial, but we've since conducted 5 R01 collaborative care trials. The first one I mentioned with anxiety disorders, we'll talk about briefly. The second was the first trial to apply a collaborative care model for treating depression to treating cardiovascular disease. In this case, it was post-CABG depression. We had a competing renewal of our first anxiety trial. This is Relax. This is when we started getting into logos and stuff. Although nothing is as good as SHARC. I love SHARC. Reducing indications from anxiety. The Hopeful Heart studies, our most recent randomized trial. This is using a blended model of collaborative care to treat both heart failure and depression. So a single care manager who's been trained up for both conditions rather than siloing it like we did in Bypassing the Blues with a care manager who's just focusing on the depression and not addressing the cardiovascular disease. And then what I'll spend most of the time this morning talking about our trial of online collaborative care for treating mood and anxiety disorders in primary care. All of these studies, what they have in common is basically a care manager. In our heart studies, our cardiac studies, we hired nurses to be the care manager role because some of these patients are going to somatize their stress and anxiety and depression as chest pain, and we thought it would be important to have nurses who could help distinguish between is this cardiac chest pain or is this emotional distress. While in our primary care work, we hired research assistants who are mostly in their 20s, to be the care managers of these programs. They were not PhD or master trained, but they were empathetic people in their mid-20s. Some had masters in public health and so on, but they were our care managers. They would use Epic, the electronic health record that's been in place at UPMC since 1999, to communicate with the primary care physicians, and they would chart in Epic, and they would also send the primary care physicians notes, with suggestions from our care management, case management review meetings. So we had these weekly meetings that would review patients' progress. In these weekly meetings, I'll show you some of the registry screens. We focused on the patients who were newly randomized to the intervention, those who weren't doing well, and those who were completing the intervention. So I would attend these used to be in person. In a room like this, we thought we were real slick in the mid-2000s. We bought a projector and we developed a paperless data management system and would project it on the wall like this and have a group discussion. And at the time, nobody else in our group had a projector. We bought a projector and attached it to a tablet. In those days, this before the iPad. I forget who it was. It wasn't LG, but they had to come up with this tablet software, and we bought all our nurses at the time for the bypass study tablets that they could twist the screen so they could, when they're recruiting people at the bedside, it was a tablet, and when they were doing case management, they had a laptop. These are the actual registries that we use for the online treatment trial, and these were sortable. So when we'd have these case reviews with our study psychiatrist and myself, or project coordinator and care managers, we could sort them by date or by what their last is this laser? Sorry, we could sort people by their last. Is this a laser? Yeah, we could sort people by their last PHQ, and so that we're not, if someone was doing great, we didn't have to spend the hour on the people who were doing well. We could focus on the people who weren't doing well. And then these were our treatments. We published our methods papers before. They were largely, SSRIs, SNRIs, bupropion. By that time, that all these medications had gone generic. I mean, we weren't using ketamine or transmagnetic cranial stimulation and stuff. We were also recommending socialization, sleep, avoiding alcohol, and physical activity, kind of keep people going. We weren't just trying to throw people on pills. And then if people didn't get better, we would make recommendations to see a mental health specialist in the community and try to connect people to the right care. So this is the main outcomes from our bypass trial. And so it's easy. I'm not going to go into details, but this work took 11 years from conceptualizing the idea of heart disease and depression to actually getting the funding, doing the pilot work, getting the funding, executing the project, whatever. It was 11 years. We started this work in 1998. And this is the main outcomes findings, where we show that people who were randomized to the intervention did better with this collaborative care. This is a non-depressed comparison group. So you can see there's still plenty of room for improvement with this. But it was significant improvements in mood symptoms, just treating people over the phone. And I said, we never met with these patients face to face. In RELAX trial, that was a competing renewal of our first anxiety trial. We were showing how the durability, the intervention went to 12 months. And then we looked to see how durable our intervention was after it was over. And then we also had a watchful waiting cohort. You try to do things a little bit different. So this was like a step collaborative care. You were randomized to intervention. If you're we noticed in our first anxiety study, the benefit went to the patients who were most symptomatically anxious. Well, if you had just, moderate levels, high enough to get into the study, like a GAD-7 above 10, but not a 15, we did watchful waiting on those people and reassessed them at 2 months and 4 months. And if they declined, deteriorated, then they were randomized. But if their symptoms stayed low after 4 months, then they stayed in the watchful waiting group. And because we found from our earlier trial that nobody bumped up after 4 months. No one clinically deteriorated on average. So this is one of my favorite quotes from Louis Pasteur about chance favoring the prepared mind. And what I mean by this, and this is probably, like having me here and me talking and learning from your experiences, you just never know, when you see something and you hear something might trigger, and meeting people, especially people who are in fields adjacent to your fields. Like I do a lot of reading, I like to travel and just keep my eyes open to and be receptive to new ideas. And one of these, so I had the privilege of being able to go on sabbatical at the University of Pittsburgh. And I was connected to people at the section for primary care mental health at King's College in London. And so we went away for like 9 months, although we did a lot. My family and I my kids were little at the time. We did a lot of traveling, and then we settled in London and enrolled the kids in school there and so on. And I wanted to learn about the English healthcare system because it was single payer, and I also wanted to bring at least one idea back to the United States. And that idea, just keeping an open mind, was about computerized cognitive behavioral therapy. So the NHS comes up with these reports from NICE, N-I-C-E, what is it, National Institute for Health and Clinical Excellence. So they're kind of like a mix of FDA and AHRQ, where they do these evidence-based reviews, and something has to be it has to be both effective and cost-effective before the NHS will approve payment for something. So initially there was a review of these programs in 2002, and they concluded that at that time, wasn't enough evidence to support NHS paying for these computer programs. But by 2006, there was. And there were 2 programs that were approved. One was called Fear Fighter, and the other was called Beating the Blues. And so the Beating the Blues product was developed by a company called Ultrasys in London. And the people at King's College some people had been involved as consultants. So I was able to network and get introduced and learn about the product. And I thought, whoa, this is great. So it was cognitive behavioral therapy program, so it's not medication and stuff like that. And it had a lot of advantages over the computerized CBT over face-to-face. It's convenient, it's available 24/7, less stigma. You don't have to show up in someone's, what they call their surgery office, for care. It was scalable. At the time, the Beating the Blues program was on CD-ROMs. So you had to load a CD-ROM on your computer to do the lessons, and then it went to streaming. But again, staying up with developments. Most importantly, it had a similarly strong effect size, whether it was face-to-face, delivering face-to-face CBT or online CBT, and that was really key. So we were using in our earlier trials, we were using these books. And we would mail them to patients, and our care managers would review homework and lesson plans. And we would digitally record also the calls, to help so that we could time the calls, so we knew for the cost analyses that we tried to do later, as well as to prevent research misconduct. So we had a recording of these calls, We bought headsets for our care managers, and they were plugged into their computers that would create a WAV file, et cetera, et cetera. And my project coordinator and I, we would audit a selection of these. And when we heard them, care managers ask a lot of times, did you have any questions about the homework? Did they do the homework? And you got, these really vague answers. No, I'm okay. I don't have any questions. It was a little like talking to your kids at the dinner table. They ask what they learned in school that day. How was school? Okay, it was fine. So we really had no way of validating that someone was actually doing the homework in the workbooks. So that was another thing that I really liked about the computer program, because the care manager could log in and you could see if the person was actually doing the program, what problems they were working on, how many minutes they spent, et cetera, et cetera. So these are some things on collaborative care and comparing that. The other thing I like, you see the effect size on at that time, there had been about 30 trials. I'm trying to show you, like, not today, but data that's contemporaneous from when we developed these projects. So at that time, there had been about 30, not 80 randomized trials reported. This was the effect size, number needed to treat. But the CBT had much stronger, larger, these are considered large effect sizes. So a lot of like mental health studies present things in terms of like HAM-D scores, HAM-A scores, PHQ-9. I like to look at effect sizes because effect sizes are like the euro. It's like a common currency. So it's easier to compare, because what does 4 points or 5 points mean? But an effect size, roughly 0.25, 0.5, and 0.75 is a small, medium, and large effect size difference. So you want to do at least 0.25, which is a minimal clinically important difference. So that's why I like reporting like there, and NNT would be another way of looking at clinical significance. So you can see, I thought also if we can put a computerized CBT program, for depression in our collaborative care trial, it would also boost our effect size improvement, taking it to another level. So here are more like studies. Again, it was really very exciting about these computerized CBT programs showing really high, large effect size improvements. So this was an article I was quoted in the New York Times that came out in 2015 when we were doing the trial. And basically it was talking about computerized CBT. And most of the people quoted in the trial were not from the United States. And they quoted me because at the time we were doing the online treatment trial, but the other people quoted were like Pim Kuipers from the Netherlands and people from Australia, Black Dog Institute, and so on, where they had developed in this article it happens to mention like 250,000 people a year in Australia are using their they had a free program. I'll show you in a moment how well it worked, but they had a free program that was available to Australian citizens. And again, but almost nobody in the United States has heard of this. And when I had visited England, I didn't know anything about this. This is this is great. This is that one thing I was looking to try to bring back to the United States. The other thing that was coming around at that time in the mid-late, the 00 decade, the aughts, the rise of internet support groups. So I saw an article, I think it was in 2006, 2007, in the Sunday New York Times magazine about a company called Patients Like Me. Has anyone heard of that? No? So patientslikeme.com. And it was developed by this guy who was looking for help for his brother who had Lou Gehrig's disease. And where do you find other people with Lou Gehrig's disease to exchange information? By that time, it had grown 40,000 and 60, 80,000, 250,000 users. So basically you'd log in and it would, depending on your conditions, it would put you into a support group with other people with similar conditions. So there had been a lot of stuff. This is another article from the Times in 2010 about these social networking sites where people connect ideally for good information. Patients Like Me, by the way, was supported by drug company money and investors. Drug companies, because they wanted to see what people were saying about their products. So from a marketing point of view and so on. And investors, because people are always looking for the new thing. So these are, there are just tons of these kind of things. D-Life was diabetes, My LVAD. Some of these are very, very specialized groups. But there's Patients Like Me. It's still around, but it's evolved. And I was really intrigued, and there's another one that I saw, this fella, e-patient Dave. I looked last night and there were now 750,000 views on this TED Talk. But e-patient Dave is an engineer who happened to develop a metastatic kidney cancer, renal cell carcinoma. And he learned about a clinical trial for immunotherapy through participating on a internet support group. And he did well, he survived, he's fully cured. And then he goes around the country, giving talks. I heard him give a talk once in person at a conference, but about his experience. Now, suppose though, if e-patient Dave had got the right treatment, but he died, or e-patient Dave found another treatment, it's like Laetrile or something else, and didn't do well. We wouldn't be hearing about meeting patient Dave. But again, these are very powerful stories for communicating these kind of social networking sites. But they have a lot of advantages, but there were no randomized trials of these. So that was the other thing I was kicking around. Nobody had really tested this. When I was looking at the reviews, there was a trial that was in progress out of Australia, but there were no US randomized trials looking at the impact of these internet support groups. It was all anecdotal information, cohort data, self-reports, and so on. The people who used these were better, and they were more likely to find helpful information. So I mentioned sabbatical. I came back in the spring of 2007, and I started writing in R01s to test these ideas. It took me 4 tries before we were funded. And the first submission might have been a 26 or 27. The resubmission was about the same score. And then I put it down for 2 years to finish up the work on the bypass project. Then I submitted again in 2010. My funding was drying up on other things. I put it in, I got a 25, a 26. I was not doing well. I was being supported in part on a bridge grant. I was doing more teaching, more clinical care on hospitalist service and patient care. And, but I had enough gas in the system to submit one more time. And I went from a 26 to a first percentile score. It was basically the same study, all the other 3 prior submissions. But maybe the zeitgeist was right, that people started hearing about internet support groups, people started hearing about computerized CBT. So you can be a little bit ahead of your time, but how do you convince this for study sections? They're innovative, you have to be innovative, but you can't be too innovative. And I didn't, again, I didn't get any smarter, but I was getting a little more desperate. But it was the best feeling. In June, I opened up the website for the NIH, and I saw I think the score was a 16, but it ended up being a first percentile. And I thought, no, it's 16th percentile, and they were funding to 10 or 12 that year. But then I closed the browser, opened it up again to make sure I was reading the right thing. I was. Anyway, we got the funding the following year. So it's a very long process, and you have to be also persistent. But even if you have an innovative idea, you have to be persistent. You have to put together the team. Mind you, I had by this time we had published the JAMA paper, the earlier anxiety work, so I thought it would get easier, but it didn't. It really it's still hard to get funded. So anyway, we're off and running. Couple of things on collaborative care. I call the 1.0 studies, the one done by Wayne Caton and Jürgen Unitzer, Craig Simon, that were done at the University of Washington in Seattle and Group Health Cooperative. It's being 1.0 face-to-face. We were moving ahead. We were doing 2.0 collaborative care. We were always doing telephone delivery. Our care managers never met face-to-face with people. But now we say everything's going online. So we're calling this collaborative care 3.0. So the specific aims of the online treatment trial was to look at the effectiveness of delivering a computerized CBT program and an internet support group embedded within a collaborative care intervention at treating depression, anxiety, and primary care. That was it. So there had been collaborative care trials, but nobody had ever got rid of the workbooks, put in a CCBT program, and then also added the internet support group that allowed patients to communicate with one another. So this is a screenshot of the computerized CBT program. You can see a UPMC logo at the bottom. By that time, UPMC had made an equity investment in the English company UltraSys. Now, the funny thing is, eventually UPMC closed down, the English company went bankrupt. And UPMC eventually closed down Beating the Blues after we finished our trial. So like the joke is, the only one who made any money off the program was me, because we got our study funded. So, but anyway, so this is what it looks like. This is the main paper that was cited in the English NHS report showing effectiveness. So you can see like the effect size improvement was between moderate to large, 0.62, and the improvement on the and this was a DVD version of Beating the Blues. We had the online version. So it's basically, these are screenshots. It kind of looks crude by today's standards, but this is what it looked like. And basically, you're learning CBT techniques, and then you're practicing what you're learning by typing in 3 problems that you wanted to work on. And those same 3 problems would go through the entire 8 sessions of the program. Each session was about an hour or so, depending on how fast you clicked. And you'd watch a video vignette up here, and then you'd practice the homework. And the care managers, so these are like the reports on the care manager portal, so they could see what are the 3 problems that the person was working on. So it's kind of like a little bit customized to you, kind of like when you buy a Dell computer, you're buying a mass marketed item, and that's what this program is. But your Dell computer feels like it was made for you because you're selecting, your processor and the color and whatever other software it might be loaded with. So Beating the Blues was like that too. You're still buying a mass market product, but you're customizing it to yourself and the problems that you want to work on. And here you can see like this is an actual report. The person is tracking their mood and anxiety symptoms at the beginning of each session. This is the internet support group that we designed. So we work with our data center in developing this. We had a lot of, you can see over here, there's search, there are different tabs. There's the top 3 new comments from discussion boards. Everything was clickable, hyperlinked. We had guest moderators to try to get engagement. We'll talk about this in a moment too, how important engagement is. But we thought we were really slick, and it took a lot of work to kind of like figure this out and continue to iterate it. This was a user profile. They can earn a badge for completing the Beating the Blues program. So, and then for posting stuff a certain number of times per month, you can earn another badge. And the badge would go away if after 30 days, if you weren't posting. So we're having all here, like, who are your members? Where's your music, books, whatever. I mean, we had a lot of fun, like trying to keep this going, but it's also a lot of work. These are discussion boards. See the last post. And then we also developed a smartphone version. So if someone was in the bathroom or on the bus or, in bed, they could also log in and see what was happening. They didn't have to be in front of a desktop or a laptop. Oh, and you can see over here, here's like our moderator, Chris. And Chris was also care manager in people in his army, who was guiding people to use this Beating the Blues program, but also being a moderator. People could also choose an avatar. Anyway, these are some of the things that we did to promote engagement. The care manager, it wasn't just you just go over there. The care manager actively moderated the posts. We allowed, as it showed here, the members to select avatars. We had status indicators like stars and so on. We didn't pre-screen the comments. We made a decision that we wouldn't review the comments and then allow people to post. It was very rare that we had a comment that we had to take down that was either identifying or flaming somebody. So we wanted, in the interest of speed, we left the comments up there. We had email notifications. We ran a variety of contests and so on to get people to log in. So I'll show you how the engagement worked after. But this is a trial design. We had ethic best practice alerts up and running at 26 primary care practices simultaneously. Our target was to get 700 people enrolled and to do it in 2 years. And you can see over here, we did not have equal randomization. So we knew everything is better than usual care. We're really interested in the digital interventions. So 300 people went to the computerized CBT and internet support group arm. 300 people went to the computerized CBT arm alone, and 100 people went to the usual care. So it was roughly 3-to-1. Preeti and I were talking about this with her pilot. Because we're most interested, again, not in the usual care, but we're most interested in how people did with the digital intervention and wanted a lot of experience with that. As in our other studies, we required people to have at least a moderate level of mood or anxiety symptoms to get in. We also powered the trial by age tertile. So 18 to 75 was the age, but when we did the power calculations, it was 18 to 35, 36 to 59, and 60 to 75, because we thought younger, middle-aged, and older people are going to use the internet and these programs differently. This is the BPA that we developed, and this is how we identify patients for the study. So we got this through the IRB, and the BPA goes to the primary care doctor, and it says the patient may be eligible to participate in an online treatment study for his or her anxiety, mood or anxiety symptoms. Is it okay with your patient if a member of the study contacts him or her by phone? If yes, click accept. So they're free to not click anything and we'll never know. But if they click accept, it would automatically send a referral with the patient's contact information to our team, like a pooled inbox. And then we had a team of study assessors who would go through, and we tried within 2 business days, to contact these people and tell them about the study, screen them, and see if they would give consent over the phone on a recorded line. So here's how we did. So best practice alert referrals, we had nearly 3,000 referrals over a 24-month period. We were able to get most of most of those patients, and most of those patients consented to undergo the screen. Little over half were eligible by symptoms, and then 704, our target was 704 met all eligibility criteria and provided informed consent. So I want to show you how we did by comparison. The very first study we did in anxiety disorders, we'll call it Anxiety 1. We hired research assistants in the waiting rooms of 4 different UPMC affiliated primary care practices. And over roughly a 3-year period or so, they approached over 8,000 people to do a Prime MD screen. And 193 of those patients were randomized for 2.4% of those who were approached to randomize. That's very similar to the studies Wayne Payton and Jürgen Unitzer and others have done at other places of how many people were approached and actually make it into a trial. By comparison, in RELAX, our first trial to use BPAs, we're up and running in 6 UPMC practices, and you can see roughly it was a magnitude of order greater of people who were referred this time, because we didn't do any screening, referred to randomized. And then in the online treatment trial, we're up and running in 26 primary care practices, and we got this many referred, and again, it's about the same magnitude of order better without spending money on research assistants to screen people in waiting rooms. This was non-white enrollment. When we did our first trial over here, it was 5%. I got a call the last month of our study from my program officer saying, you got to do better. And I said to him, we're almost at the end, we're almost done. We had our target was 191, I think, or 190, we did 193. We can't go back. We hired middle-aged white women who were the screeners in these practices. So I can only speculate that maybe people of color didn't want to be approached. They're already feeling bad. They're feeling depressed and anxious. Why do I want to talk to another person in the lobby? While here, the BPAs are colorblind, and the trusted primary care physician is asking them about the study and then asking if I could refer you for help. So we think that's what made the difference. The reason why it dropped down is because we are now in much less diverse counties around Pittsburgh, Westmoreland County, Butler County, and others that are much more far less diverse than Allegheny County. And that's why we think the number dropped. But still, it's a lot better than hiring people. These are the sociodemographics of the group. So you can see the mean age. Again, another case review that was very similar. and you can click on other things to go further. These are the numbers of sessions completed. So I mentioned Beating the Blues was 8 sessions. So 97% of people completed the first session. And then you can see over here, the mean number was 5.4, was the median number of sessions. That's an important point. We'll get to that in a moment, because a lot of times when you do internet delivered interventions, you have poor engagement, and that's a really big issue. So these are the number of sessions completed. I mentioned we were powered by age tertile. So you can see, again, if you're going to do the study, if you're going to do the Beating the Blues, most of the time you're going to complete it within 3 months. There are no differences in these groups. Now, let's talk about the internet support group for a moment. It's challenging to build online communities. Again, we have we call the attention economy. It's hard to get people's attention. There's so many other things to do. You have to get people to log in repeatedly, not just once or twice. That's why I was asking about the program that you're working with. Why are people going back to the site? We all have tons of apps on our phone that we've downloaded. Maybe we've opened them once or not at all, but it's very few, like your email or maybe the newspapers or whatever that you go to regularly. So, but you have to have helpful content. People have to perceive it as being useful. In this case, also, there's a confidentiality issue. So we were allowed to allow patients to communicate with one another. And everyone had depression and anxiety, but they used their first names, not identifiers. We didn't have home addresses or, pictures of their families. But then there's also something called participation inequality, where not everybody participates equally. So this is something called the 1% rule, which you often see in social media, where just 1% of people do almost all the work. So think about that when you're on Facebook or X or Instagram. A few people are responsible for the vast majority of posts. And to have a difference in intent to treat analysis, we need to get a broader user base, not just the 1%. So here's our engagement. So let me walk you through here. So the gold bars here are as we got to 300 people. So quarter by quarter, you can see the size of the community grow. This is the number of logins, which was roughly about 72, 73%, and that stayed stable even with the growth of the community. And then here's how many people left comments. So it's about, of the people who had access to there, also about 45% of people left comments, and it was kind of steady even as the website grew. It didn't decline, which was great as the denominator got bigger. And then this much smaller number of people are active, creating posts each quarter. So the least you could do is log in. Then the next is to comment, and then the last is to post. So let's go here. These are the main outcomes from the trial. So just to show you very briefly over here, this green line is the 100 people who are in the usual care. So you see the other two arms, the two intervention arms, the computerized CBT, they both had significant improvements over the usual care group. And but there was no difference between the people who had access to the internet support group versus those who did not. So we surmise over here that the computerized CBT program made a difference, but having access to the internet support group did not in our intent to treat analyses. But the more sessions you do, the stronger the effect size improvements. So that's kind of like what you want to see. You want to see a dose effect, right? So you have to just log in more than once. By the way, all this, you can take pictures, but all of this is also in the main outcomes paper, along with an online supplement that has more than you want to see. But you can see over here, the sessions intent to treat, and then the people who were who actually did the work. So the more sessions you do, the stronger the effect size improvement. So you really want to encourage people to log in. You can build a great website or intervention, but if people aren't logging in, at the end of the day, you can have a negative trial. We'll get to that in a moment. This is the further breakdown. Here's by the age. Here's the overall at the top. This is the forest plot. And then you can see also the breakdown by different groups. And you can see they all overlap. So across this, whether you lived alone, whether you're more symptomatic or less symptomatic on the GADS or the PHQ, and so on, you had similar effect size improvements. Charles Jonasson is one of my mentees, and he had also looked at things by race, and he found that Blacks and whites were equally likely to benefit. There was some early and greater significant, you see here the bigger drop among the African American group who started out more anxious at the beginning. But if you do the program, equally likely to benefit. So this is going back to the 1% rule. This is dropping up. So you really can't you can see how many our top 40% of postings were these, what we call these super users. Then we had top contributors, observers, and the people who never logged in to the site. So we kind of stratified, again, using principles of marketing. We had sporadic contributors, and then we looked at things, we published this. This is a secondary analysis paper because the intent to treat and the primary outcome showed no difference. But then we looked at things in the people who were randomized to access this computer to the internet support group, and then stratified them by those who were. You really can't analyze the top 1%. It's only 3 people, so we mixed it in with the next 9%. So you can see the anxiety symptoms for people who were big contributors versus those who never logged in, there were significant improvements there. So our conclusions are that we can get large proportions of depressed and anxious people to engage with online care. The computerized CBT program was effective, and we observed also a dose effect that the more they engaged, the stronger the effect size improvement. The internet support group, possible benefit, but we couldn't show anything intended to treat. But collaborative care may be the ideal way of delivering quote unquote mass customized computerized CBT. By having a human, what David Moore at Northwestern calls supportive accountability, having a person actually engage with. But a couple limitations. We only tested one computer program. We didn't look at the co-interventions. There were equal groups of people though who were getting the medications. It was about 40–50% of people were on an SSRI, up from about 30% of baseline. And but I wanted to share, this is the key point. So if you're writing any grants, planning any grants, engagement's going to be the critical piece. So we got scooped by this article that made the national press from a colleague in the UK, Simon Gilbody, 10 minutes. And for depressed, look for help from a human, not a computer. So here was his study. He used Mood Gym. That was the program I was trying to remember from Australia, and absolutely that they gave out for free, or Beating the Blues, the same program that we use. And he found no difference. Why is that? Well, look at the number of sessions. So they didn't have that human support that we provided. Our median number of sessions, remember, was 5.4 out of the 8. And hers was less than 2. It was 1.8 or so. So that engagement is really key, especially when you look at this. Simon is a terrific investigator at York in the UK, really well known in his country. He's done great work. He had no difference using the same program that we did. So where's the future going? I understand I have only a few more minutes, so the future is approaching very quickly. So I think what we might see in the future are these branded internet support groups that are deployed by ACOs, accountable care organizations. Maybe you'd have a Mayo Clinic internet support group, or a UPMC internet support group, or a UF, where you have the brand and the brand reputation, so that that it's moderated and the information out there is good and accurate. And it could potentially promote patient retention within a healthcare system, as well as attract new patients and provide information to leadership at an organization to see what people are saying about their product. I think it's also going to be really important that these are linked to electronic health records and that can anticipate patients' needs. Much like when you go to Amazon, you buy a product and says, hey, have you thought of this? Or if you go to Netflix and you watch one movie and then you're presented with other movies that you might like. So I think building in those kind of predictive analytics is really important. And of course, trust, and that's where the moderation comes. For mobile health and I think we're going to see more tailored programs, adaptive designs that address medical comorbidities. So I'm working with some colleagues on a trial that's treating depression in people on dialysis. And using these a different computerized program, but using that, addressing those medical, especially expensive medical comorbidities like cardiovascular, kidney, and other kind of things, cancer. I'll show you a slide from our digital health readiness paper that was just published. I think these are still really important. So people talk about digital literacy, but it's more than literacy. It's really readiness. So not only do you own a smartphone, which almost everyone does now, even lower income people, according to the Pew surveys, almost everyone owns a smartphone, but are you using it effectively? You know how to download an app, you know how to get onto a patient portal, you know how to post and so on. And then I think the next thing is going to be these augmented intelligence things. You've heard of AI as artificial intelligence, but I think it's going to be augmented intelligence where it's AI that kind of helps a human being, as I showed, showing you the right information at the right time. And also uses a lot of this, we're talking about passive sensing. And we coined a term for that called phonotype. So a few years ago, we were thinking about, there's some people call it digital phenotyping, but I think to stay with that kind of term, you've heard genotype, phenotype, it can be phonotype. Because the phone really knows all about you. It's collecting all this information. Everyone has one. Almost everyone has it in front of you, or it's in your pocket or purse, and it's collecting all this information passively about you. And then it's able, much more than your genetic code, but really just measuring your behavior. So there are programs like that right now, and I'm involved in a projects with the Etude Center to Prevent Adolescent Suicide at the University of Pittsburgh, where we're testing out a digital, they call it digital phenotype, but one thing I would say phonotype. We're coming out with a phonotyping program that'll sense when kids are on their phones too long and give them alerts and stuff like that. And using it in the middle of the night, what words are they using, et cetera, et cetera. So we talked this morning too, briefly about the hype cycle. So, this hype cycle is, Gartner is a consulting group like Deloitte and McKinsey. And they came up with this hype cycle a number of years ago, where you have an innovation, there's a peak of inflated expectations, the trough of disillusionment, where things don't quite work out the way that they did, and then the slope of enlightenment, where you figure out actually how to use the technology. And if you go to Gartner hype cycle and you type in telemedicine, you'll see a curve like this, but you could probably do this also for artificial intelligence or, so many other kind of things too. Here's video visits, home health monitoring, telestroke, all these kind of things. But where people thought everything, especially during the pandemic, everyone thought video was going to be replacing everything, but it's not. I think a lot of, my patients certainly made it more convenient, but a lot of my primary care patients would still prefer to see me face to face. But there is a sizable minority that likes, but we don't know this, so we're kind of in this kind of thing over here, where we're kind of figured out how to use the technology. The other thing I want to also focus on are the 4 E's. So this is a paper on 4 E's to speed adoption of cardiovascular behavioral health that I published with a cardiologist friend and another colleague. 4 E's being evidence, eminence, electronic health records, and economics. So evidence meaning is there randomized trial data to show that something works? Evidence would be are there meta-analyses that come from reputable organizations? Are there reputable organizations like U.S. Preventive Service Task Force or other professional societies, AHA, and whatever, that CDC, that endorse something like software as a medical device or something? The third is, can it connect to the electronic health record? Rather than just be siloed alone, does it connect? Is there an electronic health record? And finally, the fourth is economics, where is it saving money? Is it cost effective? What's the impact on the overall health system? So these are the 4 E's, and in the paper, we go over a couple of use case examples. But we're still needed is effectiveness trials, as we mentioned, power to treat key patient subgroups. As I mentioned, we powered our digital study by age tertile. We want to stratify by digital health readiness because Just because again, you have a phone, like Bob mentioned, I'm visiting my in-laws who live in Boca West and Boca Raton. And my mother-in-law is a smart lady, she's 86 and she can't figure out her smartphone. She's had it like so many years, she still can't do it. But she's got other friends who are really savvy and some of them are older than her. My father-in-law is 89, is savvy enough to use his smartphone. So just being college educated doesn't necessarily make you digital health readiness. She can't do a video visit. So I think that's another kind of key thing. Identifying also the patient groups who are most likely to benefit. A lot of times we come up with these interventions and they're designed for people like ourselves who are college or more educated. But what about the rest of the world? Only what is it that only a third of the country went to college? It doesn't mean that they're dumb, but you need to be like designing things for that a larger number of people can use, not just high income, high medium SES people can use. And then finally, also cost effectiveness, getting the cost piece, so that you can go to an insurance company, think about who's going to cover something and get it covered, because we all have great ideas, but if it's unaffordable, you have to, and doing this at the beginning, not at the end of the project. How best to deploy. So we talked about this before about integrating with the electronic health record is really key. There are a couple other different models, or you can hire navigators to get people set up. Oxner Health in New Orleans has navigators in their lobby of their hospitals. They curate a certain number of devices like Omron, blood pressure cuffs, and they have people actually there. They modeled it after the Apple Genius Bar. So a patient customer comes in and they'll connect you up on their app and they'll set you up on that and whatever. That's one model. Care managers we've talked about gamification, and maybe it also could be behavioral economic principles. Preeti was telling me about the program that she's using with Ryan White funds, and that if a person doesn't log in, 70% was it, that they're in danger of losing the free phone and cell contract. Those kind of like loss aversion strategies I think are wonderful to get people to engage. This is a digital health readiness slide in the interest of time. Again, these are really important to think about. It's more than just digital health literacy, but is someone ready, and thinking about these digital determinants of health is really key. Lastly, I want to leave you with this. This is a vexing. Many years I go to the Science of Dissemination and Implementation Conference. It's typically in December's in the Washington area. And that's where I saw this. And I thought at the top, it's an older paper now, 2013, but the graphic has been updated. And at the top, you see like, how industry innovates. Every year you're coming out with something new. And on the bottom, you see how we innovate. It takes, as I mentioned, like the OT trial, took 4 draws over like 4 or 5 years to finally get funded. And then you do the project, then you publish it, blah, blah, blah. And then the field has moved on. There are new programs, or in our case, the program is no longer available. So it's really hard to do this kind of innovative work on the NIH grant timeline. So this article talks about when you're doing this work, you're not testing a specific software product, but you're testing principles and you're using high quality study design. So randomization, blinded assessments, right? It could be open label that the person knows what they're getting, but it should be blinded assessments, should ideally be randomized, make your sample size, these kind of things, high rates of study follow-up. So, and then again, testing principles, because I think in the future, you can't test every app when there's a new, we see this in cardiology. Someone comes up with a new stent, and then it's a negative trial in the New England Journal or somewhere. And then you said, oh, but they were using the old stent. Now there's a newer one, So you want to be testing principles as opposed to a specific thing. Because I think like the FDA, where they have those approval processes of software as a medical device, can't test everything, but it's going to be eventually, I think, like the underwriter's lab, where you don't test every toaster, but rather, if it meets these guidelines, these principles, if the wires are insulated, it's unlikely to blow up in your house. So I think it's going to be like that in healthcare too with this software. So I'll leave you on that. And then also, we were talking also about the ISRI conference. So I learned a lot of this stuff also going to international conferences. We hosted ISRI 11 in Pittsburgh. We had people coming in from 20 countries. I've been attending this meeting since 2008, and roughly half the attendees come from outside the United States. When we hosted the meeting in Pittsburgh in September 2022, we had people from 20 countries, 19 outside the United States. So it's a really great opportunity to find out what's going on in Europe, South America, and Australia, and so on. So I'm registered to go in August and encourage other people who are interested in this space to attend and to this network. Probably about 400 people, 500 people who attend. So anyway, I'll just leave it at that. Any questions if we have time?
We can go over this today, so I think we can have time for one or two questions.
Yeah, so I guess my first question is, how do the people who were super users or top 10%, how are they different from the people who were less likely to participate in the online support group? What kinds of demographic and clinical differences do you see in these groups?
Honestly, it's in the paper. I don't want to say anything without being, because we publish, if you go to ottrial.pitt.edu, that's the website over there. And then there's a tab. There's a tab for professionals. And then there's a link to our papers, our published papers from the study. So I don't want to say anything wrong. So go over there and I believe that they were similar. There may have been some small differences, but I don't want to state incorrectly.
Thank you for your conference. So you mentioned something about using AI in order to predict and inform the team, but I wonder what are your thoughts about using generative AI to kind of customize the messages or the interaction with the individuals based on the individuals' preferences or knowledge?
Yeah, we didn't do that. I mean, at the time, because it wasn't really out there, but now there's like really exciting like chatbots, you know, that can do that. And I have a colleague in Pittsburgh, Jared Magnani, who did like a chatbots for promoting anticoagulation for people with AFib on a smartphone chatbot. But it's out there. But we had humans who were typing the messages. But I think it's really exciting area, or even augmented. I found it creepy when I started seeing this, like you go to shopping sites and then you see something in your corner of your screen with a bell saying, can I help you? You know, whatever. And then first times you think about it, you say, wow, is someone really up at 2 a.m. or like 3 o'clock on a Saturday? But then you realize you're dealing with a chatbot and anything more complicated goes somewhere else. But I think it's a really interesting technology. Bob and I were talking about the movie Her last night. Has anyone seen Her? No? It's a sequel to Him. On a serious note, it's about a guy like who falls in love with his operating system. It was played by Scarlett Johansson. Came out in 2013. It's supposed to take place in 2025. You saw Her?
I actually haven't seen it, but I have heard a lot about it, and people are talking like this is what's happening right now. Yeah.
Yes.
All right, well, let's say thank you to Dr. Rollman one more time. Everything.
Thank you for having me.
And again, if you're in our 232 training program, you